Right. Okay. So let me talk about the case. He's a 58-year-old patient admits to a surgical ward and complain of the left lower abdominal pain for 2 days. And he has fever, vomited few times. And he was a known patient of type 2 diabetes, hypertension, treated for renal colic in the previous year. And on examination, he was found to have a temperature of 39.4, heart rate of 120, blood pressure 90/55, and respiratory rate 30 with a saturation of 95. And he had complained and then on examination found to have tender left iliac fossa. And the initial ward-based management included the investigations and some management, which includes full blood count, UNE, liver function test, amylase, and the CRP had been sent. And the IV access been taken, and their favorite fluid of choice as well as the rate, 100 ml per hour started at the surgical ward. And the IV coamoxiclav was also ordered, and I assume it is started too, and the antiemetics and the analgesics. And more investigations had come. WBC 16.5 or 16,500 with a high neutrophils. CRP had been high, 220, hemoglobin 13 and hematocrit 44, platelets 175, electrolytes when you go to sodium 148, with potassium 3.2, blood urea 15, creatinine 98, liver functions, LDA-C little on the 40s, APTT also 1.12 with an INR, serum amylase 50. Okay, I will now invite the surgeon of the day, Kaushika. What do you want to do here, Kaushika?
Excellent. So we have a patient who has come with the left abdominal pain in the past week of renal colic and is having raised inflammatory markers with low blood pressure. So it seems to be a acute patient. So by the looks of it, it seems like there's significant inflammatory or infective problem going on in the abdomen. So with the given history, the differentials that I would like to consider is he would be having the past system renal colic, he may be having a UTI, which may be complicated with obstructed system. And it could be a bowel pathology such as diverticulitis, simple diverticulitis, or maybe complicated with abscess or perforation. And it could be unrelated to bowel, maybe just another intra-abdominal abscess or a psoas abscess or something like that could be possible. And also twisted bowel loop with impending perforation or ischemia. So these are the differences I would consider. So as this patient is ill, and since we were talking about different Polish systems that we could be using to detect this patient is in sepsis.
Okay.
So I thought I'd discuss about a few of them. So as surgeons, of course, we are very fond of using the systemic inflammatory response.
Not only fond, you maybe, well, I would say you only know that, but let's say, yeah.
We do use other Polish systems as well, but I think most surgeons are fond of using the SIRS.
Okay.
So which consists of temperature, respiratory rate, heart rate, and also the WBC count. So
Okay.
if we apply the SIRS criteria to this patient, so he has all four are actually positive. So he seems to be he seems to be having a septic focus as well. So if he applied this criteria, he seems to be in septic shock.
Right.
And also in the previous guidelines, they were talking about the QSO, so which is now of course not very recommended. The current guideline doesn't recommend the QSOFA, but if you apply QSOFA to this patient, again, two criteria are positive in this patient. So the reason for QSOFA to be not used now is that there may be sepsis. There may be sepsis without QSOFA, or there may be patients who have positive QSOFA signs without any sepsis.
All right.
So.
Okay, so well, what I heard from morning was the QSOFA alone cannot be used, but it can be used. That is why you used it. Right, okay, so now we got an idea that the QSOFA also can be used. All right, so and that's why it's recommended, as you very correctly said, because it might miss the diagnosis of by the sepsis because the QSOFA may have sepsis without Q and also may not have sepsis with Q. So that's the whole idea. All right, okay.
And also we were talking about the new score, the National Early Warning Score. So I have applied our patient's parameters in the new score. So if we apply our patient's parameters, so he would be using at 10. So as we discussed in the morning, as Dr. Anudhara showed that there are different zones in the new score. So our patient would fall in the red zone. So these zones would actually give you an idea as to what should be the next step.
Okay.
So when we apply this new score to our patient, so he is using at 10, so he's in the red zone. So this patient needs escalation into an ICU or an HDU setup, and I think we need a multidisciplinary team input. And I think we have to call in the anaesthetist for the management of this patient. Because the anaesthetist has to get this patient into an ICU because he's a ill patient in septic shock.
All right. Okay. Yes, I agree to you because there's no single gold standard score or test to diagnose the sepsis, and all the tools alert us. And what's more important is the clinical judgment, as you very correctly said, and giving the high credit to your very good clinical diagnoses. Yes, and also supported by the screening tools. Yes, as you very correctly said, the new score here is 10, and then already in the red zone, and we will be visiting the new score again, and it needs immediate assessment and resuscitation, escalation to the ICU, and very correctly. And I just wanted to highlight there are so many scores coming up. SIR score 2/4, SOFA score, Q SOFA score 2/3, and LQ SOFA when it comes to lactate plus 1 Q SOFA, and the national early warning score also comes in. And but do not forget high risk patient population whom and low threshold to keep on monitoring. Okay, Kaushika, you have moved into this sepsis, in other words, and what to do with this sepsis. All right, Ashani, what next? He wanted the anesthetist help, mind you.
The problem is the usual problem. The ICU bed is not ready, so you have to wait. From the morning we have been talking about all these guidelines. So here from here onwards, we will talk about how to apply this surviving sepsis guideline. So it's a kind of, as Mahen said, it's a kind of a guideline where which is made on actually the evidence that has been practiced so long, and so our patient also we are planning to use this surviving sepsis guideline. The important thing is when you are applying this, the time zero concept. So sepsis is something very urgent, so you have to act very, very quickly. So when the time zero you might not know what actual time zero is, but where the Kaushika picked the patient up, that would be a good start. So we can start from there. So act quickly. So our protocol has to be initiated then and there at the ward level.
Okay. Right. All right. So then to do what?
Then of course we are going to the proper management of sepsis, time zero. From there you have the golden hour. So from there we are going to apply our one bundle. Okay, so if you are to go to the hour one bundle, you have several sets of things that we are doing together. So measure lactate, and you have to initiate your rapid fluid administration if your patient is hypotensive or if the lactate level is more than 4. And then you have to obtain cultures before administering antibiotics, and then you are administering broad spectrum antibiotics. And if your blood pressure is still low, then you are going to start on vasopressors. And if your lactate is high, you can remeasure and reassess our patient.
All right, thank you. We'll go one by one. Let me ask you about the fluids.
Okay, so about the fluids now, as we learned about the pathophysiology in the morning, so sepsis is a relative dehydration. There is relative dehydration. Patient might have fluid, but it's in the wrong place. Anyway, vasculature needs fluid. So we are going to start fluid resuscitation as soon as possible. So the guideline, what it says is you're going to start 30 ml per kg by ideal body weight fluids. Okay. So the new thing about this guideline is now initially we were always talking about 30 ml per kg. So we are not sure how long or how quickly are we going to give this. So this guideline clearly gives you an idea whether you're going to start it in the first 1 hour and then spread it to the next 3 hours. So by the 3 hours, you should be able to give this 30 ml per kg. So if your patient is 70 kilograms, that is close to 2 liters. Okay, so 2 liters spread over initial 3 hours.
All right, but I'm sure the 2 liters cannot be given at once, right? Yeah, you should have some guide, because I heard, I think it's Anuradha who said that you have to give it fast earlier, then slow later. Is there any guide for that?
What you can do is, as a rough guide, you can think like 10 ml per kg in the first hour, and then you reassess and go on giving your fluids. The important thing about this is that you can't have a standard value for all the patients. So it's depend on your background of the patient, whether the patient has any cardiovascular or other comorbidities. So it has to be individualized when you are doing that. And then you have to assess the ongoing losses as well, and then assess your patient, and then you can decide whether the patient actually needs it. Thing is, one size doesn't fit all, so you have to individualize your patient's fluid.
All right, thank you. So you do need to individualize. That means you need to see whether this patient is fluid responsive or not, isn't it? What about that, Ashani?
So it's the reassessment. You give to it, you assess, give to it, you assess. So now our patient is still at work, so you need to have several parameters that you can guide this fluid. Okay, so means that not all our patients who are in shock needs fluid. Okay, shock can be because of other causes as well. Sepsis also associated with cardiac failure, so this could be cardiac as well. So you're going to assess whether your patient is fluid responsive or not. So how are we going to do that in the ward? So you have like dynamic parameters as well as static parameters. Okay, so static parameters, they are kind of easy, so straightforward. So you're going to do that in the ward setup. Okay.
All right. Okay. So the guideline says this to be in the dynamic zone, right? Yeah. Okay. So how are we going to do that, or what are we going to do that when you are doing the dynamic testing? What are we to do?
So we have several testing. One is this passive leg raising test, and then you can do something called capillary refilling time, which is very easy. This is reproducible also. Lactate levels, we do it all the time in a critical patient. And the skin modeling, you can check for the modeling of the skin and have a rough guide by that. And then also the temperature gradients of your patient.
Right. Okay, nice to see the capillary refill is back again, isn't it? We learned it when we learned it maybe the second year, third year when we started clinical. So it's in the sepsis guideline. It's nice to hear that.
Yes, it is actually incorporated in the new guideline about the capillary refilling. So you're going to use it as a measure of fluid responsiveness in the patients.
All right, but you said some hi-fi stuff as well, right? Yes.
So actually, passive leg raising test is not very high-fi. So you can do it at the ward setup as well. What we do is now, if you remember your Starling curve, if your patient will respond to fluid if the patient's cardiac function is in that steep part of the curve. Okay, if it is not, then the patient is likely to go into cardiac failure. The important thing about this passive leg raising test is that you're not actually giving fluids. Okay, so once you give up the fluid, you can't take it out. It's like giving a fluid bolus, but you're not really giving the actual fluid bolus. So what you're going to do is you're going to raise your patient's leg like this. So there will be auto transfusion of blood that is there in the legs. Okay, so it's like mimicking a fluid bolus. So you can assess the responsiveness. So if your patient's pulse pressure goes up, then that means the patient is responding to fluid. So it is reproducible, but you're not risking the patient to go into a cardiac failure if the patient is at risk.
Okay. So just by changes of the pulse pressure, you will be able to gauge the responders, you mean, right? Yeah.
Yes.
Okay. Yeah, maybe not the whole time, but it's good to have any other measures as well, I believe, right? Something like CDP or something?
Yes, you can. This is the ward setup. The CDP may not be available, but in the ICU, certainly you're going for CDP as well as other invasive methods.
With the same passive leg raising.
Yes.
Okay, and here comes my favorite, capillary refill. Let's talk about it.
So the capillary refilling, so this is actually incorporated into this new guideline. So it's a guide that will indicate the blood supply to the peripheral tissues. Okay, so it is easily performed and it is repeatable, and there is no harm to the patient as well, and also no cost. So yeah, we can use it over and over again in our patients just to guide the fluid responsiveness.
Okay, right, all right. So you have been talking a lot on this, but I would say, and everybody agrees to, the clinical judgment of fluid will be the best to go. I mean, you can go by the dyspnea, worsening of dyspnea, falling of saturation. This tells you the lungs are going to be wet and the fluids are too much, right?
So
yes.
if you give too much, it will be in the wrong place. So
Yeah.
you will know the patient is, when your patient is desaturating,
All
at
right.
that point you are going to stop.
Okay. So this patient had a capillary refill more than 2. and then the passive leg with the BP checking with the pulse pressure change from 8550 to 9550, and then 1000 ml of fluids already being given with our very energetic surgeon. And then should you have given a balanced crystalloid here at all?
So practice usually is using normal saline, so people 60 and steadily available. But of course, the guidelines suggest is to give a balanced crystalloid.
Okay, fine. All right. So yeah, since you have been talking about the recommendations, let me tell you about it, ladies and gentlemen. Yes, it is to say that they recommend the crystalloids of first-line fluid, as well as that they suggested to use the balanced crystalloid instead of the normal saline, even though it's a little bit of weak recommendation. And also they suggested the use of albumin in patients who are in shock. Am I right, madam? Yes. Okay. And then also they recommend against the use of starch. Why do you think that they are against the starch? What is the reason, Ashani? Why no starch?
So there is actually no evidence to suggest that starch will improve this. And if the patients have leaky capillaries, so these can go into the wrong places again. It goes to the tissue levels and leaking, that will bring a worse prognosis. So we are recommending using
Starch or starch in this situation. Same does with the gelatin as well. Okay, fine. So this is our patient again, and then let me give you the arterial blood gas as well. At the pH of 7.28, carbon dioxide of 28, and the PO2 of 89, and basic is minus 7.8 with the high lactate this time 6, and the bicarbonate is 16. So let me ask you again, what is the importance of the lactate? You said you want to check the lactate anyway.
So yes, the guideline from the beginning, upper one bundle suggests to check the lactate. So lactate is a product of anaerobic metabolism. So when your tissue suffers hypoxia, the lactate is produced. So lactate is a marker that your patient is going on for a tissue hypoxia. So when it's a good guide for your fluid resuscitation, and if it is coming down, that means that your tissue is start perfusing again. So it's
right.
a good marker.
Right. Okay. So the hypoxia means maybe secondary to hypovolemia as well, because it's a distributed type. Yeah. Okay. Mahen, I can see you just waiting. Let me give you a chance to talk, Mahen. How to and when to take the blood cultures? At least something. Yeah. Okay.
Right. So thank you very much. And after a very long time, right. So you have to collect blood cultures. Blood cultures will detect bacteremia. So in a patient like this who has a higher new score or impending septic shock, so you have to collect at least 2 blood cultures from 2 different sites at earliest possible. So you have these automated blood culture bottles. Almost all the hospitals have this. So that will give a quick and reliable results.
Okay, right. And then
what you have to do is, before any antibiotics preferably, or if you have given antibiotics, you can collect the blood culture just before the next dose where the antibiotic level is lowest. But that doesn't guarantee you for a good result. And multiple samples are preferred always. It is not the single sample, you have to take multiple samples. So here you can see the positivity. If you take a single set, the chances of positivity is 65%. But when you increase the number of samples from 2 to 3, the increasing rate, there's a positivity rate increases, with 3 being 95%. But forget about 3, at least 2 you have to take. 1 blood culture is equal to none.
So what is the sets you mean? What do you mean by sets?
Ideally, it has to be aerobic and anaerobic. In our setting with the hair dietary cuts, no anaerobic blood cultures. You have to take at least 2 blood cultures within the stipulated time period. Two bottles taken from 2 different sites.
All right, that's what you mean by sets, right? Okay, fine. So you need to take the cultures into this, but you are supposed to talk about the antibiotics also, Mr. Microbiologist.
Yes, of course, starting antibiotics. Right. So now this graph shows you the indications for antibiotics. So now if you go through these 8 indications, other than those indications, there is no indication for antibiotic usage under the sun. So now if you take antibiotic general, empiric antibiotic therapy, targeted therapy, prophylactic therapy, preemptive therapy, And then there's something called salvage therapy, suppressive therapy, combination therapy, and compassionate therapy. Other than these 8 indications, there's no indication for antibiotics because antibiotics are useful for bacterial infections. It is not useful for any other thing. So, antibiotics are not useful. So, in this patient is having sepsis. The surgeon very correctly said the anaesthetists have given fluid and resuscitated the patient. Now it is our time to kill the bug which causes all these things. So because the patient is very severely ill, I would suggest.
What do you want to suggest? Which one is
salvage therapy?
Oh,
so
right,
that is
okay.
to salvage the patient's life. So forget about the antimicrobial resistance. Now in this instance, so you can liberally use the broader spectrum of antibiotic that you have.
All right. So when the things are moving to the other side, you are going to have all these others like combination and all sort of things. In this particular patient, salvage, right? Okay. Here comes that. And this is why we have started the IV meropenem, I believe, under your guidance. Okay. Right. So here we go. Again, the patient. So more than 1,500 ml of fluids are being given. Blood pressure is still very marginal, mean is to coming up to like 60. Let me ask our sweet little Senani, what are you going to do now?
Thank you, madam. So, as you can see, now we have resuscitated the patient according to the guideline. We have given more than 1,500 of fluid and still the MAP is 60. So, what can we do? So, this is an indication for us to go for vasopressors, right? So, the preferred vasopressor according to the guideline is noradrenaline, which is the first line vasopressor. So we are not hesitating to go for a central line. So the newest guideline, the addition is to go with even with a peripheral cannula. So preferably if you can place a neck cannula in the external jugulas will be better. And so the starting infusion for convenience, we have the guideline is recommending 4 milligrams to be added into 250 milliliters of normal saline, which is easy to prepare even in any of the settings other than the ICU, where you get a 16 micrograms per cc dilution and will titrate according to the mean arterial pressures. Okay. So the maximum regime will be to go with 0.2 mics per kg per minute. So you try and titrate it and see, and let's see what happens when we go up on the rates.
All right. Okay. So what you are going to say is it's in the recommendation. She has never moved out from the recommendation. That is to start the vasopressors as early possible to keep the mean pressure more than 65, and it is a strong recommendation. And application of noradrenaline from the peripheral line. Can you talk about it a little more? I mean, we do it, and how are we going to do, and where to put the cannulas? Can you give me some idea?
Yes, as I mentioned, so it's preferred to have a bigger vein where the dilution is more rather than in a smaller vein in the periphery. And if you noted, the dilution was in 250 milliliters. That is what is recommended. But in ISO setup or in the theaters, we do it in 50 cc. But you can see it is more diluted. So the injury or the harm by giving a more concentrated drug is less. Right? And so it's only for a short period, mind you. So you should get the proper access within 6 hours. And and it should be well placed, and preferably the anticubital fossa is also taken as a site recommended in the guideline, because there you find a bigger way with easy access, right? And it unlikely to cause local tissue injury as well.
Right. So make sure, Kaushika, even if you start it on the peripheral line, it's 6 hours, right? Only. So within that, try to push your anesthetist somehow to give the ICU bed. But anyway, we are with the recommendation, which is suggesting the patient to the ICU within 6 hours, and we are really, really good people. So we have given you the ICU bed, right? Okay. So here now let me summarize the patient again, ladies and gentlemen. The patient was taken over to the ICU on admission. The patient maintained the airway with a high flow oxygen started at 60% and reduced basal air entry dose, saturation 94. Respiratory rate 24. If further desaturated, we were thinking of starting the CPAP. We got it ready. And then the systolic pressure is 78 with a mean of 52, even though we have done all, but the heart rate 120 empty. Capillary refill prolonged still. White bow IV axis is there. Blood has taken Mr. Microbiologist, culture and the sensitivity, and repeated full blood counts, renal and liver functions, ECG, troponin. Antibiotics escalated, as you very correctly said, for the IV meropenem. This time we have ordered it and got it also, right? And the radial artery line inserted, and invasive blood pressure monitoring had been started. Lactate still 9, base excess minus 15, base excess is 15, minus 15, pH 7.23, and the PF ratio of 300. And the right internal jugular CV cannulation has been done, and the noradrenaline switched to the central cannulation now, and then targeted mean pressure 65, and also we are hourly measuring the urine output. His GCS wise drowsy 14 over 50, as well as he's restless. Random blood sugar 20 at 12, and then the insulin variable rate was started and targeted to 4 to 10. Abdomen was tender. Is your patient Kaushika? When the abdomens are tender, I mean, we call you more for many reasons, but this is the time that you need to get involved, I believe. Yeah.
Yes, so as we suspected from the initial presentation itself, so this patient seems to be having an intra-abdominal pathology. So now that we have done the initial management, the next step would be to actively look for the source of infection and to control it. So source control, one of the basic management is to find for the source. So as in our setting, as ultrasound scans are, so go for the imaging. So because we are thinking of an abdominal pathology. So in our setting,
this is common with all the surgeons. Their phone rings all the time. Yeah.
It's the anaesthetist.
Calling you, I believe. Yes.
So we have gone ahead with an ultrasound scan of the abdomen, so we can see the findings. So as usual, they have noted some probe tenderness in the LIF and seen a thicker bowel with the surrounding hypocake facts, such as an inflammatory process and some free fluid in the pelvis. So now we out of the differences we were thinking, so now we are pointing more towards something involving the bowel, and now we have safely excluded something involved. And but we are not quite sure as to what the pathology. So there is a thickened bowel loop, so it could be a tumor, or which is a tumor with impending perforation, and diverticulitis is also high on the card. So just a simple diverticulitis may not warrant surgical intervention as well. So I think here we would need to go ahead with the imaging like a CBC to identify whether there is an abscess or any other complications of the disease process.
Right, okay. Yeah, I think since it is being called the multidisciplinary team, we should never forget the importance of the radiology team, even though we have not invited them here. So this is where the radiology team also comes in, just like the microbiology, giving them the best support to us. All right, let me now invite my dear friend Sidarshi, because she has massive experience of intensive care and scoring patients. So what could be done in the ICU? Now they have been scoring Sidarshi, Q so far, and SIRS and all. I'm sure we can go a little more further, right? So what could be done in the ICU to have this scoring to identify the severity?
Vasanthi, can I touch on the news to score before I get on to the factor of talking about organ dysfunction?
Right.
I think this is the best forum for me to talk about the news to score, because this has been implemented by the UK SP, and the recommendation is to emphasize the thresholds and triggers of news score. Now, what do we mean by that? Now, you can see there are 4 colors: white, yellow, orange, and red. Now, when it comes to white, the patient is stable, no issues. But when the patient's score goes up to 3, that more than 4, the patient go into the yellow zone. And then if the score goes over 5, that is between 5 and 6, the patient goes into the red zone, orange zone. And that says that the patient is having a medium risk, and we have to respond very quickly, urgently. And what do we have to do at this point? We have to immediately screen the patient for sepsis, which means that we have to send the bloods to the lab to screen the patient according to the SOFA score. So and the other thing is, if the score goes over 7, that means the patient has to go to the ICU. Patient is a critical patient, and our response is an emergency response. So the thresholds and triggers are given in colors, and which is actually illustrated in this chart. And apparently this chart is used in many of the private hospitals. And right now the college is emphasizing on using this chart in our hospitals also. So all the BHTs carry this chart. Probably the ones whom we are talking about in the orange zone should carry this chart in our BHTs also. So what does this say? Now, this is a chart for the nurses and for the doctors in the ward. And when you all are charting the news parameters, you can see where the patient is. If the patient is in the white zone, no issues. But if the patient is crossing the yellow zone, you have to be alerted. If the patient is in the orange zone, that is score 5 and 6, which means you have to send the bloods. The red zone, we have to think about the patient going into the ICU because the patient needs immediate critical care. So I would like to suggest all of you all, because I can see a lot of faces from all the departments. This chart is in the MSD, and we have to get it down through the pharmacy, and we have to, I think, use it. And it is a very user-friendly chart where we can, understand where the patient is, and the team will trigger with that. Thank you, Vasanthi.
Yeah.
So let me just get on to the next slide, which the question you have asked about how to assess the organ function. Now, as everybody correctly said, that the organ dysfunction is the main issue of septic shock. And I'm very happy that Kaushika and the outreach team, they have managed the patient very well. And now we are, getting the patient after sending all the blood investigations to the ICU. So the blood investigations that we talk about are, one is the arterial blood gas. Second, it is the liver functions. Third, it is the renal functions. Fourth, it is the full blood count, where we are talking about the platelet count. So we are assessing 6 organs. What are the 6 organs we are assessing? Respiratory system, cardiovascular system, central nervous system, liver functions, clotting profile, and renal functions. Okay, so Vasanthi, can we get on to the other slide?
Yeah.
Thank you. Now, you can see the quick SOFA came from this SOFA score, which we are now not very happy about. But SOFA score, we are very happy about it, because this is the one that is giving us an idea which organ is failing. Now, you can see each score has 4, 1, 2, 3, 4. So if you look at the blood gas, and in the blood gas, if you have a PF ratio which is less than 300, and it will give you an idea what score you're going to go on. Then your central nervous system functions are assessed with the GCS, and it also gives you a score of 1, 2, 3, 4. Then comes your clotting profile, the platelet count, score of 1, 2, 3, 4. Bilirubin levels, the liver functions are assessed, and the cardiovascular system is assessed with the mean pressure and the amount of inotropes that are used to hold the blood pressure at that. So the last one is the renal functions, which will give you an idea with the creatinine levels and the urine output.
All right. Sidarshi, you heard many times Senani was struggling to get this investigation reports as she had been calling everywhere. And every time you just heard her phone ringing as well. So it's the investigations that has been arrived. So WBC 20,000 and the platelet 200,000, HP 12 and the CRP now is very high, 264. Look up for that Mahen, I'm going to call you back again. And the serum creatinine 200, sodium 145 with potassium 5.1, bilirubin 24. And as very correctly Kaushika has called for an urgent contrast CT abdomen, which was requested. So now the reports have come. I'm sure you will be able to gauge this patient on a sofa, right?
Yeah, thank you, Vasanthi. Shall we move on to the next slide? Okay, now let's see what is happening with our patient. Now, we have a platelet count more than 200, which means the score is 0. And our bilirubin level is between 20 to 32, so the score is 1 there. And the patient's PF ratio is at 300, score is 2. And the creatinine level is somewhere around 200, which means the score is 2. And the patient is on noradrenaline more than 0.1, that means the score is 4.
Okay.
So altogether, the SOFA score is 10, which says that the cardiovascular system is deranged, renal functions are going down, and lung is atrophied, and also our liver functions are also going down. So basically, there are a few problems that we are concerned about in this patient.
Okay, yeah, I too agree to you. Now, this is where our tachycardia is also comes in. Yes, this time the blood pressure is still low with a mean of 52. Even they have started on at 1.25. And should we add another vasopressor or inotrope, do you think, Sidarshi?
Well, yes, now as Kaushika and the outreach team, Senani and Ashani, they have done a great job, and they have actually stuck to the recommendations, and they have started norepinephrine, which is the first line, and actually it is having very strong recommendations and very strong evidence. But we have some other vasopressors that we can consider. I would just like to give you the level of evidence. Dopamine, high level of evidence. Vasopressin, moderate level of evidence. Epinephrine, low evidence. Celepressin, low evidence. And angiotensin, 2, very low evidence. So what are we going to do right now with this patient? The patient is on 0.25 to 0.5% micrograms of norepinephrine. According to the recommendations, vasopressin is the second line of vasopressor that we should start, and apparently it has moderate level of evidence with weak recommendation. What about adrenaline? Well, if the patient is not getting the targeted mean arterial pressure, which is 65, with noradrenaline and vasopressin, probably the next drug would be epinephrine.
As a vasopressor, as a vasopressor, right? As a vasopressor.
Okay. As a vasopressor, where we have low evidence and weak recommendation.
All right. So, and the septic shock, as we very correctly said, she very well explained which one to start. So, as I think there is a recommendation waiting for you. You can highlight it on that as well.
Can I just emphasize on this slide, Vasanthi, that is in septic shock, why do we have to start vasopressin? We have to start vasopressin because we find in septic shock, within the first 24 to 48 hours, there is a vasopressin deficiency. That is why they recommend that. Then the next reason why we have to start vasopressin is it has a catecholamine sparing effect. Thirdly, if you start noradrenaline and go up on noradrenaline, we are going to get arrhythmias. So if you add on vasopressin, you can actually avoid arrhythmias. So the combination of noradrenaline vasopressin has reduced mortality, and it also has reduced arrhythmias. So that is the combination that we look for in septic shock.
All right.
Thank
Yeah, let me highlight again. So this time, by adding the vasopressin, we are not going to actually go for the vasoconstrictor effect by the receptors per se, but through the ADH. You know, that's the deficiency. So that's why it is in the place there. Okay,
Yes.
fine. All right. Okay.
Shall I now summarize this for some?
Yeah, sure.
So let's to quickly summarize what I have already told you about. It's very important. First line, norepinephrine, and right now here we call it noradrenaline. Second line, vasopressin. Thirdly, if you can consider adding dobutamine or switching to epinephrine, if you don't get the right blood pressure, unless the patient is, I think better to talk about dobutamine a little bit later, isn't it, Vasanthi? So your third line would be epinephrine as far as the vasopressors.
Okay. So as a vasopressor, we are going to start. And another question I actually wanted to ask, which you actually told me earlier as well. Now, before that, I think this particular one has been already said, because the epinephrine or the dopamine as a vasoconstrictor you start, and then the drugs levosimendan and telepressin are not recommended, I believe. That's what you said, right?
Yeah, Vasanthi, one more thing, I think, why, if noradrenaline is not available, what are we going to do?
You just said that you can start, or maybe if it is not responding,
epinephrine and dobutamine.
Yeah, okay. So if it is not available, or if it is not adequately vasoconstricted, you can go for this. And we do not have a place for levosimendan or the telepressin, even though the West is talking about it. Yeah. Now that's about the vasoconstrictors. Let me ask, maybe I'll switch to somebody else, maybe Ashani to talk about, or maybe Senani, whoever you want to talk about the inotropes.
All right, yeah. So just to add a little bit more, actually, depending on the evidence. So there are strong recommendations and weak recommendations. So in the strong recommendations, what they say is to go ahead with noradrenaline, and you increase the doses and you see the response. If you don't see the response, you go for vasopressin, right? And then, despite correcting the fluid level and maintaining the MAP, if your patient is still kind of not maintaining the desired outcome, such as the urine output or the rest of the organ functions, then there is a place for you to assess the heart. So probably the myocardium may be the culprit. So that is the place where the guideline says to go for dobutamine.
As an inotrope.
As an inotrope. So you can add dobutamine or epinephrine, that is to support the heart. Actually, dopamine has gone out from the, in the recommendation, what they say, there are strong recommendation against dopamine. When you compare noradrenaline.
Yeah, that is because they can go into cardiac arrhythmias. That is the reason mainly they were not talking about it. But having said that, since because this particular guideline 2021 include a lot of Asians. For the first time for the guideline committee, they included a lot of Asians. And from the Southeast Asian countries, they produced evidence for the use of dopamine. Sometimes we don't have anything else other than dopamine some time ago. So that is why they were still talking about it, as Ashani and Senani very correctly said. There's no place for it if the others are available, especially because the patient can move into some arrhythmias. But as you very correctly said, as an inotrope, you can use the dobutamine and again the epinephrine, which again has a beta stimulant action and can work as an inotrope, right? Okay. So I'm now going to ask, I think Ashani, yeah, how to assess the hemodynamics in the ICU, Ashani? How are we going to do this?
So now we come to dilemma whether the heart is the problem or the vasculature is the problem. So as Senani correctly said, if the heart is the problem, then you have to use inotropes instead of vasopressin in addition to vasopressin. So this is one way that we decide whether the problem is in the heart or the vasculature. Now we have very sophisticated monitoring systems in the ICU. So you can see some of the clinical monitoring, NIBP, pulse rate, capillary refilling, urine output, so those parameters, and then CVP. And we have ultrasound now, so you can guide ultrasound guided CV inferior vena cava to see whether the patient is full or not. And then you have FICE, that is echo, where you can do a bedside assessment of your cardiac function. This is not the echo that is done by the cardiologist, so you can do a bedside assessment. And in addition to that, we have several cardiac output monitoring systems, flow track, lead code, things like that. So by doing that, you can identify whether the problem is in the heart or the vascular.
All right, I'll come back to it. Yes, the patient is now started on vasopressin. The vasopressin has a regular dose, right? You can't escalate or increase. It is one dose. It's 2 units per hour or rather 0.03 units per minute. So it started. And as you very correctly said there, he's been started on dobutamine as well. And we have called for the transthoracic echo, which is globally dyskinetic and cardiac functions on the point of view of that. And also the respiratory rate has come up now, 40. Oh, the FiO2 60, yet to start it, increase it. And the blood gas shows the pH of 7.1, but the PO2 still holds in lower range of 72. And CO2, because he's hyperventilating, 33, and the base X is minus 17. Here comes the PF ratio is 120. Sidarshi, I'm going to also show you this X-ray and ask you what to do now.
Vasanthi, can I touch a little bit about the dobutamine before I start?
Yeah, sure.
Dobutamine, as Senani and Ashani very correctly said, the recommendation says that if there is a perfusion problem, while the volume and the pressures are reasonable, then you're supposed to add dobutamine. So it has a reasonable recommendation, which has moderate evidence, I think. Okay, let's get on to this bad blood gas, which Vasanthi has given me now. I think I'm in trouble. Basically, the patient is having a very high respiratory rate, showing that the patient is in respiratory failure. And the blood gas also shows severe metabolic acidosis.
Hypoxia.
Patient is hypoxic. PF ratio has gone down from 300 to 120 with a PaO2 of 72. So the patient is in respiratory failure, hypoxic, and is having metabolic acidosis. On top of it, you showed me an X-ray which has bilateral lung infiltrates, which is suggestive of ARDS. So I wouldn't hesitate to intubate this patient and ventilate this patient and ventilate according to the ARDS lung protective ventilation protocol. All right, just a minute about the recommendations. Vasanthi, I think we have to emphasize on this because the recommendations have there are no recommendations because there's insufficient evidence about 3 things. One is the target oxygen level. What is the oxygen level we are going to target while we are ventilating? No recommendations because there's no evidence. Second thing is whether high flow nasal oxygen is better than non-invasive oxygen. There's no recommendations as such. And also there's no recommendations to say that non-invasive or invasive ventilation is superior to each other. No recommendations. Reason, there's no evidence at the moment. So, okay. Shall we get on to ventilating this patient?
Right. Yeah.
Right. Okay, now as you have correctly suggested when the patient was in the ward about non-invasive ventilation, well, the recommendations suggest that it's better to go on high flow nasal rather than CPAP if the patient's lung is not very bad, but our patient's lung is very bad. So that is why I thought about ventilating this patient. Okay, so when it comes to ventilating a septic patient with ARDS, which is in our patient, we have to go on low tidal volumes, 6 ml per kg. That is having very high evidence with a strong recommendation. Okay, the next thing is about the two pressures. Now, the recommendation is very strong, evidence is moderate. Apparently, we are not supposed to go more than 30 centimeters water with our plateau pressure. We have to keep it down we should not go on very high blood pressures. So that is the recommendation given for that. Then those days we used to go on feed from a low value to higher value. But right now in this recommendation, the level of evidence is such moderate evidence, and it's a weak recommendation though. They say go on a very high feed initially rather than going in low feeds. Then the fourth one that they have.
Let me ask you that. A patient, let's say, is septic induced lung is there, but not in the ARDS.
Yeah. So if they are not in ARDS, but their lung is bad, needing ventilation, we know that the patient is septic. Well, again, we have to go for low tidal volumes, which is 6 ml per kg when we are ventilating the patient.
All right, so little is better. All right, I think I better call Kaushika again. So we have ventilated the patient, we have done a lot of supports on the musculature, and you know very well that we can't do without you. Here comes you, Kaushika. So what to do with this patient? You have to treat the patient.
Yes, so we got the results of the CT scan as well, and that is suspected clinically the patient is having a complicated diverticular disease. So the CT shows multiple sigmoid diverticulum with a concealed perforation with treatment in the pelvis. However, there's no gross pneumoperitoneum, so this looks like a concealed diverticular curve. So in this patient, I think because patient is ill and septic, so we need to go for source control. So sometimes especially in diverticular perforation, if it's a concealed curve and if the patient's other parameters are okay, there are situations that we would manage them non-operatively as well. But in this patient, I think he wants urgent laparotomy for controlling the source. So we can talk about source control. So the main objectives of source control, as we said, the first part is identifying the source, so which we have done through our clinical assessment, the biochemistry, hematological investigations as well as imaging. So next part is getting rid of the infective focus. So the main objectives of source control would be to get rid of the infective focus and therefore reduce the microbial further contamination and the microbial load, so that we can expedite the recovery process. So when we talk about source control, it depends on the system that is involved. So we as surgeons mainly are involved in a lot of intra-abdominal, urinary, and soft tissue infections, but sometimes there may be other infections as well, so maybe pneumonias, which we cannot do anything really unless there is a pleural effusion or something to drain it. So there are, depending on the organ and the system involved, we may use different techniques to control the source. So broadly speaking, we may drain the systems, we may remove them surgically, and there can be decompression. So if we are talking about draining, so it could be surgical draining, as well as we can get the help of our intervention radiologists to place guided drain. So even in an intra-abdominal collection, if we could, if there is a abscess, because currently with an abscess, if we could drain it radiologically, that would be the best thing to do, because rather than adding surgical stress to this already compromised patient, that would be a good option. And then, having said that, if we cannot do that, we will have to go for surgically and drain it surgically and remove the infective foci. So let's see what our patient had. So we went ahead with a laparotomy. So we had a perforated sigmoid diverticulum with the colic inflammation, and there was momentum and other bowel loops has come and concealed the perforation, and there was pus in the pelvic cavity. So in this kind of a situation, so what we have done is we have taken off the sigmoid colon, so we did a sigmoid colectomy and washed the peritoneum with copious amounts of fluid. So one principle is what we do in this kind of situation is what is called damage control surgery. So we won't be going into doing a reconstruction, or we will do what is minimally required to get rid of the infection. So that's why we have done a colectomy, and we will not go ahead with an anastomosis or reconstruction in this kind of a situation. So the aim is to do what is necessary to control the infection and to come out quickly and push back the patient to the ICU to again to get the physiology back into the normal. So we have not
Okay.
anastomosed, we have gone ahead with
Just
the
into-
stoma.
Yeah, okay. This is the picture actually. We need to follow your surgery, otherwise we can't manage this patient. So this is one picture one of our anesthetists send us what is happening inside the theatre. And then of course you have done the surgery what is needed. And during surgery, we all continued the fluids, NORAD continued. And as you said, the post of the ICU, we brought the patient back to the ICU and then planned to the continuation of ventilation. And Sidarshi, back again onto your show to manage this patient with this time a 5 to 8% and arterial blood gas with very low pH, lower than the earlier 7.01. Oxygenation also affected 60, carbon dioxide rising, and the base Sepsis is also minus 17. PF again dropped even less than 120 to 75. And here comes the text X-ray. What are we to do, madam?
Thank you, Kaushika, for controlling the source, but the patient is a little worse than what he was. Oxygenation has gone up, pH has gone down from 7.5 to 7.0, and we have dropped our oxygenation and carbon dioxide levels are going up, and the 502 is pretty low. Well, now this patient is in severe ARDS, so let me just remind you on ARDS a little bit, which is the 2012 Berlin recommendations that is classifying mild, moderate, severe ARDS. It's a pulmonary manifestation of multi-system dysfunction, which we call acute respiratory distress syndrome. The mild ARDS is where the pH ratio is between 200 to 300, where we have a peak over 5, and moderate ARDS where the pH ratio is hanging on 100 to 200 with a peak more than 5, and severe ARDS where the pH ratio is less than 100 with the peak over 10. So our patient is having severe ARDS with a pH ratio is less than 100, with bilateral pulmonary infiltrates and acute onset. So, what are the recommendations in managing this patient on ventilation? So, part of this patient's lung is gone. Now we have to recruit this lung. We have to get this part working. Otherwise, we are not going to get him out of the ventilator. So, how are we going to do that? We are going on low tidal volumes, 6 ml per kg. Can we go on inverse ratio ventilation? Because it is going to help the patient to open up the lung, the ones that are filled with secretions and which are closed up, which is not taking part in gas exchange. 1-to-1 ratio, can we do that? Well, the PSCO2 is 56. So our threshold to tolerate the PSCO2 is at 60. We talk about permissive hypercapnia, isn't it, Vasanthi?
Yeah.
Yeah. So 56 is not a good number to go on 1-to-1 ratio. But if the CO2 has come down, I think we can consider going on inverse ratio ventilation. We are giving more time for the alveoli to open up in our ventilation. But then we have to paralyze this patient and with non-neuromuscular blocking agents. And also we have to go on a high peak, and we have to consider keeping the plateau pressure less than 30. So shall we talk about the recommendations that are given on this, Vasanthi?
Yeah.
Okay. So if we have to go on traditional recruitment strategies, but we should not go on incremental peak titrations. That is not recommended. Traditional recruitment strategies, there's moderate evidence and weak recommendation. If we are not achieving our improvement in gas exchange, we can think about prone ventilation. Earlier, they were not very happy to keep the patient prone more than 12 hours, but in the current recommendations, according to the level of evidence, it is actually moderate level of evidence. They are highly recommending the patient to go on prone position more than 12 hours. And about intermittent neuromuscular blocking agents, they recommend us to give in intermittent boluses rather than giving in an infusion. So that has moderate evidence and weak recommendation. And lastly, if I talk about ECMO, I think if lung is so bad, and if we can't go on conventional ventilation, if we have the facility to go on ECMO, that is a way forward.
All right. Okay. So there are so many anesthetic and ICU registrars here. So it's very important that you're mentioning the ARDS management and surely about the proning, and make sure that you have to make sure that there are no contraindication to proning. And then if not, you can, and it is more than 12 hours can be continued. Mahen, I really see you like this. See on this? I really see you like this. Let's show some colors, Mahen, here. We have taken it anatomically, we try to reduce the focus and whatever the drugs that we have been giving, and here comes your bunk.
Yeah. So the whole idea of having a clinical microbiology laboratory in the hospital is to help to identify the organisms which causing disease. So when you identify the organisms which causing disease, you can target them and start treatment targeting. So that is narrow spectrum drug to kill the bug. But initially we have used the concept of salvaging because of the fact that the patient is ill and we didn't have a bug. So now here we get the report. The report says the traditional culture method, and the report says blood culture report isolated history of producing Escherichia coli. So that is a common organism which can cause intra-abdominal sepsis. And if you neglect the treatment, the patient can go into endotoxic shock and die. So here we have a patient with a compromised system and a blood culture drawn E. coli. So when we see ESBL, the term ESBL, so you can't give any of the beta-lactam or beta-lactam inhibitor combination. So no cephalosporins, no cefazolin, no piperacillin tazobactam. So you have to give meropenem in our setting. So there's a very good trial called Merino trial, which compares piperacillin tazobactam versus meropenem for treatment of ceftriaxone resistant bugs. And the Merino trial, they had to stop halfway because so they have seen a lot of failures in the pip-taz and ceftriaxone. So therefore, as we have suggested on empiric basis earlier, so meropenem would be the drug of choice for this bug.
All right, we knew that you are a very good predictor. That's why you started meropenem and we continued. And nice to see that it is still, whatever the name is given, is susceptible to meropenem. But don't worry, I'm going to give you some more. PCT 23.5 and the CRP 345 plus.
Yeah. So now these are the two tests that we use most often. CRP, because most of the hospitals have access to do this thing. So remember, these two tests are not standalone tests. So that is number one thing. So if you get a high CRP alone, it's not an indication for aggressive therapy. So you have to follow it up with another one, right? That's one way. But on this patient, a single value of so this is a patient who had sepsis plus surgery. So if you can go through the yellow color graph, you see any patient who is undergoing surgery, the CRP is invariably going up. So this is a normal variation after surgery. So it will go up till day 3, 4 and come down. So that is a natural progression of CRP. So if you do a CRP in a post-operative patient within 1 or 2 days, invariably their CRP would be 300, 400, and without getting the pretest probability of infection or this thing, so you won't be able to diagnose because you can't differentiate the infection from inflammation, inflammation of cervical trauma with this. So therefore we are going for.
So does the PCT?
Yes, same with PCT. So that is why Surviving Sepsis Campaign guideline says, so you shouldn't start solely on one single value of progesterone. So they have not mentioned about the serial. They have said on one.
Okay, now I know why you reject our PCT request. I do agree to you now. Yeah, okay. So right, let me ask my girls again. So what needs to be done? Let's talk about other therapies, Ashani.
So we were talking about this inotropes and the antibiotics mainly, so which are the part of our one bundle. So what is additional to this? In the morning also we were talking about the corticosteroids. So steroids are the thing that we give to everything. So when in doubt we give steroids. So in here also we give. Actually, the guidelines suggest you to give corticosteroids. So it's given in this dose. So 200 milligram per day. So you can given it as an infusion. The guideline actually suggests to give as an infusion, but we usually practice as 50 milligram IV every 6 hours.
Curious, right?
Curious. So we recommend when the epinephrine noradrenaline dose goes more than 0.25 micrograms per kg per minute for at least 4 hours.
You will add the cortical. That again by the guidelines coming and going, right? Yeah, it's always. My era people like Sidarshi, we have been listening to many changes of guidelines in the past, and this is one thing coming and going, changing of doses and all. But anyway, steroids still holds true. What about the glucose control, Ashani?
So the glucose control, it's not much difference from the management of other critically ill patients. It's the same. So you don't go for very tight control. So it's they have given a very you have to start insulin if your glucose level is more than 180. But the level they have given to range, they have asked you to maintain is around 144 to 180. So it's not very tight.
Does it change to any diabetic patients?
So again, it doesn't say anything about that.
All right, this is the range they say. Okay. All right. So what about the transfusion strategy? How do you manage the transfusion?
It's similar to the other critical ill patients. You don't go over transfuse our patients unless there's a indication. So you are trying to keep more than 7 grams per deciliter. That's the target. So you're going to keep at least 10 in patients with comorbidities like myocardial ischemia. Otherwise, no transfusion.
Okay, so you can go down if it is not needed, but certainly if there is any other comorbids, you might need to go up and this thing. But about the platelets, so we know that this will be dropped, especially in very septic patients.
Again, the indications are similar for any other patient. So in ICU, we transfuse patients with platelets if the count is less than 10,000 or without any bleeding. But if your patient has a platelet count between 10 to 20 with bleeding, you transfuse. But if you're going for a procedure or anything like that, you are trying to keep it more than 50,000. Otherwise, if your patient's count is more than 20,000 without any bleeding, you don't need any transfusions.
Right, okay. So earlier also you wanted to talk about the hemodynamic monitoring as a little stronger ones in our other improved one in the ICU. So this is the time for you to tell us that.
So we were talking about all this because the registrars are there. So the invasive ones, that is the place where we use these invasive ones. So especially the pulse contour analysis ones, and you can judge this by your stroke volume variations and the pulse pressure variations using cardiac output monitoring in the ICUs. It's very important that we use them in patients with stroke.
All right, okay. So I'll leave it to the experts to do the SPV and the PPV variations. Okay, let me give you the patient's condition now, ladies and gentlemen. By 36 hours of admission, the NORAD is 2 or rather 2 mics per kilogram per minute. Still the low MAP. Urine output is less than 0.5. Cardiac output monitoring flow track as being 1000. And then stroke volume variation of 8%. And systemic vascular resistance 750 dyes per cubic or rather cm of 5. And vasopressin infusion had been started. And then IV hydrocortisone, as you very correctly said also, is being running. And the blood pressure is further dropping. Arterial blood pressure monitoring started. Lactate has increased to 11, but no PPV or SPV with fluid boluses, passive legs or capillary refill is still, now it is still it holds to more than 2. And despite a rise of mean arterial pressure to 60, Persistent metabolic acidosis is there with a pH of 7.1 with a negative 17 of base excess and a lactate of 12. And the renal functions have come to us now, urea of 18 and the creatinine 280. Let me ask Senani, what are you going to do now? What are we to do now?
Thank you, madam. So in this context, you can see we have corrected the mean arterial blood pressure, but despite that, the metabolic acidosis is continuing, and it is going into a refractory metabolic acidosis. And previously mentioned that the urine output has been less than 0.5 ml per kg per hour good going hours. So that is now we are heading to few indications to go for renal replacement therapy. So according to the guideline, so what they say is AKI, which requires renal replacement therapy. It suggests using either you have to go for continuous or intermittent renal replacement therapy depending on patient's hemodynamic stability. And so we can initiate it as the continuous voluminous hemodialysis. So the guideline recommends to go for renal replacement therapy in patients with sepsis and septic shock. But so you can go for this is to facilitate management of the fluid balance, or also the patients who are having hemodynamically unstable situations, where you can mop up the acidosis and support the anatropes. And also it should not be used, but should not be used of for increasing creatinine or urea alone. So there are definitive indications. For example, if a patient has gone into AKI, there should be a urinary complication, one complication or more. And also you should have refractory acidemia, or else you should have refractory fluid overload, or else there should be hyperkalemia. So according to the guideline, if a person is not having these features, you are not going to start on renal replacement therapy despite patient is in sepsis or septic shock.
All right, that's a very good point actually. Just because the urine output low or the creatinine is high, we are not rushing into CRRT. We just see whether other complications are also there for us to move to this. These are not very good procedures anyway, isn't it? And you can go for intermittent or continuous depending on the hemodynamic stability. What about the bicarbonate therapy? Is that a place?
Yes, for bicarbonate, what they say is in hypoperfusion induced by lactic acidemia. So they say not to, it suggests not to use sodium bicarbonate therapy to improve the hemodynamics, so to reduce the vasopressor requirements. But if you have a severe metabolic acidosis where the pH is less than 7.2 and ongoing AKI, which scores to a Aiken score 2 or 3, there bicarbonate therapy is suggested with strong recommendations.
All right, that again was moved from here and there with recommendations, right? Sometimes it was saying no bicarbonate, but now they have given a little bit of green light. If you have this particular situation, you can use it, but if not, I already asked you, Mahen, the next burning question of the inflammatory markers. It's keep on coming high, but you want to still hold true with your this thing, is it? I mean, the procalcitonin. Do it again. Do a repeat one and see.
Yeah, if you have the facilities, yes.
Okay, so make some facilities and do a repeat one and help us with that. Okay, so if it is continuously rising, then you will guide it for that. What is the place for it then if you are not using it?
So it's actually speaking now. So now these guidelines were made in order to suit all level of hospitals and all level of countries. So if the surviving sepsis campaign guideline really endorses on serial users of procalcitonin, that would be a big problem for management of patients in low and middle income countries.
Okay, so how frequently you want us to send you?
So half-life of procalcitonin is 18 hours. Theoretically, it says that it increases in case of uncontrolled sepsis within 24 hours, 48 hours.
Right.
And if you want to repeat it, maybe after 4 days. So if you get a 80% drop within 4 days, so that is an indication that you are in the correct track, and you can omit IV and you can convert it to orals.
All right. So is that what is called the stewardship? The
Yes,
antibiotic
yes.
stewardship. All right. So say so. Use the nice word. So it's used for antibiotic search. So very good. What about the sedations, girls? What about the sedation, Ashani?
So we can use as for any patient who are mechanically ventilated, the patients they need sedation. But we are here, we are trying to use minimum sedation as possible, either intermittent or continuous sedation as per the patients who are in typically patients on ventilation.
All right. Okay. And about the stress ulcer, again the same, right?
It is the same, madam, similar with the other patients, only if it is indicated.
Now, when the patients are in the ICU, we are talking so much about the thrombosis and DVT and all sort of things. What about that as well? Can I ask from Senani, please?
Yes, madam. So, what the guideline recommends is, the strong recommendation is use of thromboprophylaxis in sepsis. And the recommendation is more towards low molecular weight heparin when you compare with unfractionated heparin. And also, there was another comparative study they have done with the mechanical venous thromboembolism versus the prophylaxis medical management with pharmacological therapies. So there was no kind of added advantage of using both, but generally we use both. But there was no significant benefit in using both. There was no kind of outstanding
advantage. So
yes.
if the patient has been started on pharmacological, you can be told not to, maybe if you don't have any this thing, we can hold the mechanical devices in
Actually, it was done only one center. That is why the evidence is not strong.
Yeah, that's the thing. So sometimes we do both, but even maybe the reason we don't have very much DVT, I don't know. We'll wait for the next guideline to see.
So
what about the vitamin C? Vitamin C, we just during the COVID period, isn't it, Anuradha, there was so many surge of discussions. Senthil, agree to me? There's surge of discussion about starting vitamin C critically ill and all sort of things. Is that having a place here?
Again, few centers only have described about vitamin C use, and one center has talked about IV vitamin C plus thiamine use, where they have shown that the vasopressor requirement has reduced. But again, when they have done the meta-analysis and all, it has not given strong evidence. So the guideline team has come to a consensus not to add vitamin C as a recommendation. That is why they have given overall ideas against.
All right, okay. All right. So another multidisciplinary team member in the current day ICUs are the nutritionist, right? So even though I could not invite the nutritionist here, what about the nutrition? Maybe Ashani can tell us.
Madam, just as a contraindication, you can start feeding this patient within 72 hours and saying that this is a place that I would consult Kaushika before starting.
Yes. There are a few things that we don't touch in these patients, Kaushika, especially if they had a bowel surgery. We will wait to the surgeon to suggest that about the feeding. So do you agree that not to continue the
we also would like to start feeding early as possible.
All right,
also,
okay.
Especially if it's possible to start parenteral nutrition, because parenteral nutrition has its own set of complications.
Yes.
So this patient, only the issue is this patient has a risk of developing an IBS because of the bowel handling, and if the sepsis, we may have a chance of developing an IBS, but early nutrition again itself says that it will lessen the IBS. So we would usually start with 3 fluids, maybe minimal doses, minimal amount, maybe at 30 to 20 cc per hour, and we see how the patient tolerates.
Okay.
And one option would be we can keep the NG and then start feeding. So that would giving a stimulant orally will also promote the bowel function as well. So we can help them to recover from the IBS.
Yeah, okay, you are right, because it's not only an advantage of starting the enteral, but the disadvantage of parenteral also needs to be thought of. So much of electrolyte disturbances, so much of acid-base disturbances, a very increased chance of critical illness, neuropathy and myopathy at the end of the day. So many are coming up on the parenteral. So we do need to start, but not that early, and if it is not needed, better not to, but maybe just to add a little bit more onto the requirement. What about the use of immunoglobulin? Ashani, it comes very flashy all the time. Start the immunoglobulin.
So it is because now with sepsis everything has been tried. So immunoglobulin is one thing. But of course, the guidelines suggest against using immunoglobulin, so we should not be using immunoglobulin.
Only to manage the sepsis. In other words, if it is needed for a different reason, like, you can be complicated with a lot of medical complications, you might need it, maybe some other things, but not the sepsis per se. Sidarshi, you were to start about talking about the venous ECMO. Can I ask you again?
Yeah, actually, there is a recommendation to go on venous ECMO. Only thing is, in our setup, I don't think we have that facility, but if the facility is available, I think, and also if the conventional ventilation fails, we can try on
All right, yes. I think as a center, we have venous ECMO in Gaul, right, Nandana? We do have in Gaul. So there are some situations that we have to fulfill before we even ask for it. And I've tried a few times, so there are very less chance of getting a bed. But having said that, the success is also still doubtable. And yes, but there is a place when there is in other countries. I mean, we go very quickly to ECMO and then treat them. Probably Mahen now might be Ashani can help me with this. What are these, polymixing B hemoffusions and then the blood purifications and all? Ashani, you might be able to tell us. They come behind us, right? To get this filter, to get that filter, madam, please.
Yeah, so they're supposed to remove the complements and complement systems and all that, and by saying that they purify the blood, so your septic response, the abnormal response will be less. Okay, so that's the idea. So we use it. We have actually used it ourselves also. But of course, in this guideline, there is no recommendation for using it. Probably there has not been much studies done on this area because of
but when it comes to something, Mahen, you want to say something?
Yeah. So now this the issue is now when you consider the pathogenesis of sepsis, as I have discussed earlier, so there is a cytokine storm, very rapidly progressing cytokine storm. Theoretically, all these filters and this sort of thing might work, but when you put them into action, they're not shown any functionality.
Yeah.
Maybe other than the placebo effect, no other functionality, because sepsis has multiple pathways. So if you block one pathway, so it will progress in the other pathway. And another thing is now this patient's damage has already happened. So now what we are doing is we are just supporting the system to maintain till the patient's body automatically recovers. So therefore, the chances of this hi-fi, the filters and all these things absorbing material, so it's very low compared to.
I agree. But I'm also with Ashani. We have also tried a few times for patients who can afford to, and I don't think we have got the good results either. But it's not in the guideline. Probably it might come in future. I don't know. Yeah. Okay. So then let me then talk about our patient. There he is. And now, with all this help, this control, the patient's clinical parameters all improved. And the metabolic acidosis resolved with lactate, which became less than 2 during the following few days. So thanks to Senani, she has started the CRRT, and all of them started the anatropes, and cultures with the great boxer cultures revealed an extended spectrum beta-lactamase, and he has managed the patient with histol meropenem. And then supportive managements all started: enteral feeding, DVT prophylaxis, peptic ulcer prophylaxis, vasopressors as required. So then finally the requirements were reduced. Urine output started to improve. CVVH was weaned, and on the day 12, the sedations were held, and the patient was appropriately extubated, and we removed the CVVH. And then by day 14, all supports removed, and he was discharged to the ward the following day. I think we all want, and which means a clap. Yes, but that doesn't mean it stops there, right? We need to think some more things, and that's the most interesting part. Let me invite Senani to talk about the goals of care when he talks about sepsis.
So we have done a collective job for the patient, but in these guidelines, they further takes another step, which is a very important part that highlighted in Mahen's talk also in the morning. So we have to have our goals of care. So, it comprises of various components which I'm going to take you through. So, they recommend discussing these goals of care and the prognosis with the patient as well as the family. So, the patient might not be in a very good cognitive functional state, so you might have to discuss with the family. So, with the strong recommendations, they say your discussion should happen within 72 hours of admission of the patient to the relevant caregiving place. And if it is more than 72 hours, they have shown that there is not good evidence for you to say it is a successful practice. But however, they have not found any kind of specific criteria to say, let's say, you have a criteria, let's say, for arbitrary, patient's hemodynamics are worsening. So that is not an indication to start your family discussion. Likewise, they have not identified a criterion as such. So still it is yet to find the trigger to kind of
Start discussion.
initiate the goal of care discussion. So then the next part is about palliative care. So here it's a multidisciplinary approach again. You need to approach with the palliative care teams, and you need to address his issues. So this will ultimately come up with a treatment plan. And also the patients as well as the family needs to be informed, and they might need separate counseling. The family members, they may be suffering because of this illness and the prolonged hospital stay. And you need to do the appropriate referrals to the support groups, right? And there should be a structured handoff process. That is, you have to mention the critically important things verbally as well as in written. That is known as the transition of care, which again goes to a certain amount of recommendation. And also you need to screen the economic problems and the social support. If they don't have adequate support, you need to address that and get the necessary needs done. So the other thing, very important thing is the sepsis education for the patient as well as to the family. So we want to make another episode similar to this. So we can maybe we can have a discussion, a seated discussion as well as a written verbal discussion as well as a written discussion about how to diagnose, what are the signs, and how we are going to seek for treatment. And about the post-operative, post-ICU care, there are post-sepsis syndromes where patients go into long-term mental disturbances and how we can follow them up. So in ICUs in Sri Lanka, we have set up some post-ICU care clinics, especially in the Western province, where they look after the patients who were discharged from the ICUs. So it is a good opportunity for them to come back and seek the treatment. And also, it's very important to make shared decision making, again with good recommendation according to the guideline, and you have to plan the discharge. So when you plan the discharge, so again, it is a transition situation where you need to transit the patient from the ICU to the ward, and from the ward again to the community. Right? And you can give the written recommendations and verbal hospital discharge summary. Right? Finally is the post-discharge follow-up. So you can, they recommend the assessment and the follow-up of the physical, cognitive, as well as the emotional problems after the hospital discharge, where you can use one of your clinics. And also, you can have rehabilitation programs, and especially for survivors after mechanical ventilation. So you need to follow up with the physiotherapists and all the rest of the physical support, right? And so going to screening for sepsis and performance improvement. So it is recommended that the hospital system should have performance improvement systems or programs for this sort of patients. And it includes sepsis screening for acutely ill and high-risk patients. So where you can flag them early.
All right. Also, I think programs like this to improve the knowledge of the staff is also to improve the knowledge. Yes, thank you, Senani. So it's a team approach, and critical care specialties all needs to be involved with the multidisciplinary teams. The trick here is the early identification of the sick patients, and that's why your outreach team is more important. And the importance of early detection when we talk about it's not just to treat the recognized sepsis because it is so subtle. The presentation can be very subtle, and then that is where your scores and all these things needs to be there to early identification, because even though we think that we have time, the clock is ticking. So that's what the early recognition, which is the key, because it is a time-sensitive disease. So if you don't recognize a severely septic patient, all the points that we spoke about here and the protocols, everything, null and irrelevant. So the many physicians advocate this alternative time zero. It could be the time of diagnosis, it could be the time physician-based diagnosis, or maybe chart-based, or the moment they come to the ED and where the triage and all those things are important. So most important thing is to understand where the time is, and then, because if you don't understand or recognize this time zero, you might falsely initiate the treatment prior to the actual onset of hypotension. You might, which one to give first, the fluids or the antibiotics, or which one to give, blood cultures or what. So all these will be initiated if you falsely recognize the time zero. And also the other thing is the number of observed cases meeting your severe sepsis criteria may be changed if you do that. So diminished awareness of organ dysfunction other than hypertension may be the trick to diagnose. And you just witnessed the multidisciplinary team, and also this is where I think Mahen will talk about the Asia-specific Pacific Sepsis Alliance and the Sri Lanka Sepsis Alliance. And coming before that, let me thank the whole team with the multidisciplinary approach for this. Over to you, Mahen.
Yeah. Before that, I have a suggestion to the surgeon of the panel, comment for the anesthetist in the panel, question from you, madam, and a request from the audience. So four things. First thing, suggestion for the surgeon. So now when you open up, if there's any pus or something, it is always better to take it and put it to the blood culture bottle, and that will give a very early and reliable result. So that is into the blood culture bottle.
Oh, that's a point to remember.
Yes.
Right. Good.
For any abscesses taken from deep areas, always better to put it into the blood culture bottle. Any place.
Did you know about it, Kaushika? Blood culture.
Yeah, we do
All right.
take samples when we open
Yeah,
up,
we do, but
not
not to the
the
blood culture.
but
All
we
right.
always take it into
Yes.
I knew you are going to give me some point here.
Yes.
New
And
points.
second one, the comment on the panel. So now when you're giving antibiotics, especially in sepsis, think of giving a loading dose. Even if the patient is having advanced renal failure, acute renal damage, try to give the normal dose for 48 hours. So because most of the time, when you manage a patient with sepsis, the one thing that we notice is underdosing. Underdosing is not recommended. So overdosing, not a problem for 48 hours. And the request from the audience is come and join this allied team who's fighting against sepsis to prevent preventable deaths. And the question from you, madam, why all the ladies in the panel and you wearing pink color, beautiful pink color sarees?
Oh, that's a question. All right. Don't you know, sir?
That
The
is
color.
Vasanthi requested us to wear pink.
I'm a little bossy, and I told every one of you to wear pink, and I forgot you two boys because I just remembered how ugly they would look like if they wear pink. So let them do. It's because pink is a color for sepsis, so we call pink sepsis or sepsis pink. So that's why all your logos and everything is with the pink. And you forgot to tell the College of Anesthesiologists, at least in one corner. So we are there as well. So we are in partnership with the College of Microbiologists and the College of Surgeons and all the others. Yeah, all are in the Sepsis Alliance. So welcome to join us.
We forgot to tell Mahen and Kaushika to wear pink.
Well, I did remember, at least they should be having a pink tie. Kaushika, of course, had a pink tie. I did remember, but I was not very sure Mahen does. So thank you very much, everybody, ladies and gentlemen.